least studied phase of the menopause journey is peri. It's barely recognized amongst healthcare professionals as a thing. I mean, I get feedback all the time. That's not a thing. It's made up. No, I'm like, not made up. It's actual thing. So we don't have a lot of data to say, clearly you should do X, Y, Z. We don't have a lot of algorithms, but I can kind of walk you through what I do. Early perimenopause, there's things that are definitely due to low progesterone and irregular ovulation. So we can give progesterone, or usually early, we can do a progesterone supplementation only. We can do it continuous or cyclical, and low enough doses to where it won't inhibit the ovaries' production of estradiol. Now, once the estrogen deprivation starts happening with the hot flashes, night sweats, there's a few things that are really, really like, you can't blame it on anything else. So that's definitely menopause, low estrogen. And so then we can to supplement her through those low bits, give a really low dose patch, not enough to suppress ovulation. You still need contraception just in case, but enough to kind of shore you up through the transition. Now, a few patients, I'll decide to suppress ovulation, especially if they're having really heavy periods or really bad PMS and I just want to suppress. So occasionally I will use a higher dose and maybe a birth control pill. There are some birth control pills with estradiol. So with just plain estradiol, not ethinyl estradiol. So, it just depends on. So when we look at birth control pill versus menopause hormone therapy, the biggest difference really is dose. And then we look at formulation. And so I try to stick to what the ovaries made, because I'm giving you back the water you were drinking, which is estradiol and progesterone, which is Prometrium, the brand name, oral micronized progesterone. So it's really individualized. It's some trial and error. I ask my patients to bear with me. I wish I had a cookie cutter, like, you get this and you get this, but I tell her, and you know what, this might work for a year or two, but you're still changing in the background. Your ovaries are still, going through that process of ovarian failure. So as you're getting closer, we may need to do dose adjustments. So just bear with us.
I know in the perimenopause, kind of transition, so many different situations. Obviously, women can be dealing with other things as well, like maybe they have low thyroid function. And so I did that. It is very unique and in a way very complex. And I'm interested in is, am I setting myself up for success systemically, metabolically, muscle wise, brain health?
So we have pretty good data on mental health that's been looked at. So women who started hormone therapy in perimenopause have less exacerbation of pre-existing mental health disorders and less new onset. So we know that you start early, you're going to do better. Looking at the data from the WHI, we did get good data out of the WHI, all the cardiovascular data. So the earlier someone started in proximity to their menopause, so maybe she was peri, the lower her incidence of heart disease. So it's really more about, when we look at risk, metabolic risk, it's the gap away from estrogen, the time away, the more increased risk. So there's nothing magic about 60 or 10 years. It's just, if, a lot of people are like, well, my doctor said I can only have my hormones for X amount of time, it's not going to be worth it. I'm like, no. The further you get away from your starting hormone therapy in your menopause, the less likely you are to have benefit of protection from cardiovascular disease and stroke and dementia. So as early as possible. Not a lot of data yet, because not a lot of women are being treated in peri. They're being told, come back when you're a year without your period. We can't treat you yet, but we're getting there. So for like heart disease and what's going on in the brain and the brain plaques and dementia, estrogen's better at prevention than cure. Mm-hmm. So once these processes have started, estrogen's probably not going to be helpful, or reverse those changes. And so I'm just encouraging patients as young as possible, if you want the maximum cardiovascular benefits, the maximum brain benefits, the maximum bone and genital urinary benefits, we need to start this as soon as possible.
Okay. Thank you. And I was curious, I'm going to have you share how to know you're in perimenopause and menopause in just a second, but also when you recommend a baseline of labs for women. So let's say lipids, hemoglobin A1C, fasting insulin, ApoB, triglycerides, HDL, we can get baseline early. Let's say at 45, even though you still probably look good, maybe you're doing okay, but you've got this timeline of labs. And at 45, you see an uptick in these labs, even though maybe symptom wise, you don't necessarily notice anything yet, right? Because it's silent.
Yeah. Perimenopause begins well before your periods, well before you have a hot flash. And so the minute they get to my office, no matter, and most of my patients are coming in for menopause or to get ahead of it or in perimenopause, I'm getting the whole set. I want to know their baselines. I'm asking them to bring in their labs so I can look and have a baseline to compare. But remember, average age of menopause is 51. Normal is 45 to 55. Peri starts 7 to 10 years before that. So some women at 35 will start having changes that we can associate with menopause. Some women, it won't be till 45. So I'm checking everybody.
I'd love to talk about some of your other favorite tools that you find really help to move the needle on top of hormone, what I like to call optimizers.
So, outside of hormone therapy, which is a big part of the discussion, I use the word toolkit, toolbox with my patients all the time. And nutrition is really the most important thing. So she comes in with a 24-hour recall. We look at what she's eating, how much, how often. I'm getting some nutritional labs. And we're really looking to see where her deficiencies are. Like, that's an easy thing to fix. I'd say 85, 90% of my patients are not just low, deficient in vitamin D. And multiple reasons for that. Gut microbiome changes, intake is low. We're protecting our skin from the sun, and for good reason. And so, we got to get that shored up. Magnesium, people are not getting enough magnesium in their diets, omega-3 fatty acids, fiber. So when I frame it, a lot of women are coming really motivated about the weight part of it. And really that's what brought me to the table for my own menopause, was the frustration with weight gain, that I couldn't get off. And what was this happening with this inner tube around, where's this belly coming from? And when I frame it in terms of let's get rid of the visceral fat, here's what you need to do, everyone pays attention. So let me give you so these were actually studies done in menopausal women, and women who got 25 grams or more of fiber in their diet per day have less visceral fat. Women who have less than 25 grams of added sugar, not sugar found in fruits and veggies, but sugars added in cooking, processing, and alcohol, have less visceral fat. Women who have diets rich in probiotics, and usually with, yogurt, kimchi, miso, or supplements, do better. Turmeric has been shown to be helpful independently, as well as berberine can be helpful as well. There's a few other supplements, so when I address it, I'm not like, this is going to cure your menopause. No, the only thing that's going to cure your menopause is getting an ovarian transplant or considering hormone therapy. Nutrition can go a long way, because with menopause, we see so many areas that we can work on. And when you're just focusing on calories, we're so often just missing the bigger picture.